Good morning, everybody. My second brief, so those of you who sat through this yesterday and listened to me, this morning's is really about managing diabetic foot wounds and the current trends in management. It's an old quote from an old book, but diabetic foot ulcers are the most challenging wound healing problem faced in modern medicine. I think very few people will disagree with that as a quote and a statement. They're complex, and it's back to knowing what you look for and knowing how to deal with them. The risk factors for foot ulceration, I'm teaching granny to suck eggs, I suspect, but just to remember, it's the simple things like their glycemic control, duration of diabetes. The longer you've had diabetes, the more likely you are to have the complications related to the disease, and the more likely you are to have foot problems. Peripheral vascular disease is an added complication, as is visual loss, be that it's blindness or visual loss, your retinopathies, your chronic kidney disease. As I said yesterday, more and more people are surviving longer and being able to avail of dialysis and transplantation. And your age, something none of us have any control over, unfortunately, but the older you are, again, the more likely you are to have foot problems and to develop ulceration. The local issues, your peripheral neuropathy, your foot structure and the deformity, trauma from your footwear or other things related to your neuropathy, from the simple things of pouring a drop of hot water over your foot and burning it when you're making a wee cup of tea, right through to much more complex things. Footwear, callus, we all know that callus is a precursor to ulceration in these high-risk feet. A history of ulceration. That is the most important fact with regards to patients with diabetes developing a second and a third and a fourth ulcer. Once they've had one, they are much more likely to have a second and a third and a fourth, which is why you see them back time and time again at clinics. Prolonged pressures, which is much more your area of expertise than mine, and the limited joint mobility related to the glycosylation of your collagen as a result of hyperglycemia. So that rigidity that comes in those tissues due to that. So those are your main risk factors for diabetic foot ulceration. So what is a diabetic foot ulcer? Well, there are lots of definitions, and if you look at the literature, they'll try to tell you, oh, it's if the ulcer has been there for 4 weeks, 6 weeks. But in fact, the international consensus in 2007 very clearly defined a diabetic foot ulcer as a full thickness wound below the ankle in a patient with diabetes, irrespective of duration. So whether it's there 2 days, 2 months, 2 years, it's still a diabetic foot ulcer. Not if it's there 4 weeks, it now becomes a diabetic foot ulcer. From the day it appears. So what do you need to know if you're going to manage these? You need to know how to assess them, and you need to have an idea how to manage them, or how they should be managed. Go back one. So your clinical assessment. Again, I'm not going to teach granny to suck eggs. Your vascular assessment, your neurological assessment, and have a look at their footwear. You're much more used to doing that. Well, we all should be doing it. And checking inside, because it's amazing. Some people collect in their jam jars all the things they've tipped out of a patient's shoe, from the inside of a car door handle to a piece of Lego or a budgie feather or whatever. Some people have those jam jars, I don't. So anyway, so your basic good clinical assessment, what have you got there? Don't ever try to treat a diabetic foot wound without making a basic assessment. And as I said, again, many versions of this, but it's just to remind you how diabetes affects the lower limb, and whether you have vascular disease or neuropathy, or as I said yesterday, your neuroischemia, you are susceptible to foot ulceration. And that is your pathway. There's lots of different versions of that, and you will get the ones that take you beyond ulceration to the dreaded word of amputation. So your principles in managing diabetic foot ulcers. The management of infection. Key. You have to identify it first, of course. Likewise, your vascular disease. That needs to be managed. You need to offload, and as I said yesterday, we're not the best in Northern Ireland at offloading. We're getting better. We've developed a total contact casting service and what have you. Onwards and upwards. Ulceration management, and this is what I'm going to focus on this morning. the core skills that if you're a podiatrist, you learnt as a podiatry student of debridement, and transferring those across and knowing when it's within your practice limitation to debride these ulcers and when you need to refer them on to people with that interest and expertise. Dressings, well, we'll talk about that one. The whole thing of prevention. Prevention is much better than cure. But it's amazing how often people come back and they've sat on their foot wound for a few weeks. They didn't want to bother you, love, because they know you're busy. Instead of coming back early, but ideally prevent them and prevent recurrence. Someday that will happen for us all. And that cornerstone to everything you do with a patient with diabetes, their metabolic management. Management of not just their sugars, but their hypertension, their hyperlipidemia, and if you can, get them to stop smoking as well. So all of that. So, we're going to look at ulcer management and the principles of debridement and dressings, but before that, as I said, never ever manage them without assessing them. Look at where they are. Sometimes that gives you a good hint as to what might have caused it. The site, the anatomical location, the size of it, and the depth of it. The wound bed, the state of the wound bed. What sort of tissue have you got there? What's going on? Your surrounding skin will give you lots of clues if you want to play detective, from the fact that you could have diffuse callus related to neuropathic ulceration. You can have your red raw tissue where you have a high level of exudate and the excoriation that comes with that. The wee hint of the treatment the patient has tried to use. Some of those medicaments that they buy in the local pharmacy. There's one, and I can't now remember the name of it, that used to leave a red sort of glare, that's an ulcerism, right round the edges. And you used to say, oh, are you using it? I can't remember what you call it, horrible stuff. The odour, and there's criteria even for the odour. There's no odour. Then there's the odour as you take the dressing off. And then there's the odour that fills the room and you go out and you come back in again. And it's the one that stays in the back of your throat when you eat your dinner that night and you think, oh, there's their ulcer again. So those are the three, actually. I know, it sounds foul, but we'll stick with it. Pain. Pain is a good indicator, especially in your neuropathic foot, that there is infection there. Okay? If you have an insensate foot and the patient is complaining of pain, just have a wee bell ringing there. I know one of our other wee bells was for Charcot, but think infection and potentially deep infection, okay, with wound pain, especially if they're neuropathic. The ischemic patients, likewise, bells ring. Your wound management, your principles, the key things are debridement, dressings, and what we'll call advanced techniques. And the aims of debridement, you all know this, you all should know this, to get rid of that slough and necrotic tissue and the surrounding callus. We know callus is a precursor to neuropathic ulceration, as I've said, but to let you see what you're actually going to try and manage. Likewise, I talked about tissue sampling very quickly yesterday, and I said, don't take that surface gunk and send it to your lab. They don't want it. They want the deep tissue, so get rid of that superficial slough that's just sitting there, probably moist and smelly. Have a full look then at your underlying tissues and where does the wound go. Neuropathic ulcers are a little bit like icebergs. What you see isn't always what you get. Have a look in there. Use your sterile probe that you would use for probing to bone to diagnose osteomyelitis potentially, to see where they go and whether it's tracking deeper. Sometimes your hands are quite good as well. Provide drainage of pus and exudate. Let that all out and take the pressure off your tissues. By doing so, by debriding all of that, you will also reduce your risk of infection. You'll allow those samples to be collected. And the theory by that paper way back from Steed is that you're putting your chronic wound back into the acute phase by debriding it. It may also help what you're going to actually apply to the wound, okay, depending on your thoughts on wound dressings. So, debridement. What are you going to debride and what are you going to use? When are you going to do it? When's it appropriate? And sometimes it's best to just push your chair back rather than lift a scalpel and get your patient revascularized before you intervene. It's all about clinical judgment, and that comes with experience when you're dealing with high-risk feet. Who should debride these feet? And there's a new document out, some of you might be aware of it, which uses the tripod framework and says that the new graduate will be able to manage under supervision those very, very simple wounds, but they should not be managing the likes of that until they get the experience. And I'm sure some of you would prefer not to have to manage that as well. Where are you going to do it? As a domiciliary visit with the cat climbing over your dom box as you're trying to sort of get some sort of a clean field to deal with this? Are you going to do it in your podiatry clinic, or is the best place for it a theatre? All of those things need to be considered before you lift a scalpel. Sharp debridement is still seen as gold standard for the diabetic foot. But you need to have made your diagnosis. You need to know what you're about to tackle there. Is this a nice, big, juicy neuropathic ulcer that you can have a really good go at, get rid of all that callus, get it down to bleeding, and it should heal? Take the pressure off, take the callus off, make sure there's no infection. 90% of those should heal within 6 weeks. So, know what you're handling before you start in there with your scalpel. And then what are you trying to do? Are you being conservative in what you do? Are you being palliative in what you do? And those are my heart sink patients, the ones who are unreconstructible, who come back for palliative care, and we'll talk about them in a minute. And is your debridement going to be active, proactive, or are you going to be passive, again, until maybe you get your vascular intervention? You're going to use your debridement to release the fluid and to manage your exudate then within that wound. Part of that as well will be odour management. We talked about that, and I know some of you don't like the thought of that smell filling the back of your throat. Will it help alleviate pain by releasing the build-up of fluid in the tissues? It needs to be skilled. And sometimes your debridement is post-surgical if you work in a secondary or tertiary care centre, where the team you work with, be that it's orthopods or vascular surgeons, you have an amputation site there that you may be involved in. I work with a couple of surgeons who don't always close the wound with sutures. And again, is it going to be radical debridement, or is it going to be quite conservative? Your wound care, there's some evidence for it. There's some evidence for debridement. It is cornerstone. So it will let you open up your wound to see the extent of what's going on there. That needs a good debride, without doubt. Are you going to release the pus and see what's going on in there? And this is where podiatrists, as podiatrists, we get blamed for making wounds bigger when they go to see the nurse or the doctor. I went to see that podiatrist that took a scalpel to my foot, and look at the size of it now compared to what it was. Well, in fact, what you're wanting to do there is to try and provide some drainage and see exactly what lies beneath. It will also allow you to get in there and get your microbiology lab a true sample so they can see what is going on, as opposed to sort of the gunk sitting on the surface of your wound. And that's a swab rather than tissues, but... And as I said, the paper by stage, you're moving that chronic wound back into the acute phase by lifting your scalpel. So that all is part of your role if you're prepared to manage these wounds and tackle them with a good sharp knife. And there are lots of different ways. It doesn't have to be your scalpel. You can use the good old maggots, and those are the free range ones. Most people are much more comfortable with the ones that come in the little bag that you can control. Don't have to chase them around the clinic floor when they come off. Nature surgeons, they do a fantastic job if you use the right product for the right wound, because you can put maggots on wounds on feet that haven't been revascularized and they will just slough over again. Okay, so it's selecting the right wound to use the maggots. Maggot therapy has become very expensive. Okay, Versajet, our vascular surgeons love Versajet. It's used in theatre. Scalpel and lock and forceps, or if you're not comfortable with any of that, of course, some of these products that are available. The risk with using those, especially on your neuroischemic foot, is that you're creating a very moist environment where, in fact, good practice would be to keep it dry, and you can actually make the tissues much more boggy and much more susceptible then to infection. So debriding your neuropathic ulcer, as I said, this is the nice big juicy ulcer that you take the scalpel to, but you're removing callus. These wounds have lots of surrounding callus as a rule, and you're removing pressure. You all know about pressure. It also lets you see what's going on underneath, and it also gives you the opportunity to remove any slough and non-viable tissue from there and to take out those undermined edges so that you see exactly what you get. Neuropathic ulcers, as I've already said, are a bit like icebergs. It's what lies beneath. What I also want to remind you about with these neuropathic feet is callus with that little bit of redness in the tissues has been referred to as hemorrhagic callus, bleeding into that tissues, and again 50% of these, when you debride them, you'll expose an ulcer. And again, is this where we're blamed as podiatrists for causing foot wounds? So you have to say, I'm about to debride this, and you may have an ulcer underneath it. We described it, I talked yesterday about our CREST wound care guidelines, that this is actually a clinical emergency, because you've got to see what lies beneath. And it's a paper by Rosen, if anybody's into their papers and into their references, and it was published way back, 85, I think, in Cutis. Okay, the neuroischemic ulcer is a very different one to take a scalpel to, and this is the one sometimes it's best to just push that sake back and make sure they get their vascular intervention. And once they've got that blood flow, once the plumbing has been fixed, then you can debride. They tend to have minimal callus, they tend to occur on the non-weight bearing areas of the foot, and sometimes you've got that dense necrotic tissue with them. And again, this is down to experience and clinical judgment as to whether you would lift a scalpel to that. I would be much happier if somebody lifted a scalpel to that than put a piece of Duoderm or one of those hydrogels onto it. A scalpel, you have control. You also use your debridement skills potentially to assist amputation sometimes. So you get a foot like that. And with time and patience, chairside amputation, assisted amputation, using your scalpel skills, working to your line of demarcation, and you end off with a foot like that. And a revascularized patient. Likewise that. If you're into your wound management, what exactly are you going to select and what are you going to try and do to manage that wound? Well, again, your assisted amputation. Be patient. Disarticulate it, lift it off, and now you know what you're dealing with. Yeah? As opposed to that sort of monkey black toe sitting there, which of course was bound to be smelly as well. Now you know exactly what tissues you've got there and how you're going to deal with it, and onwards and upwards. Your post-surgical wounds. If you work in tertiary or secondary care, you may end off having some of these come through your door to take on management of. And it's all about teamwork. Diabetes really lends itself to teamwork. So, I talked a little bit about palliative. You've got your elderly lady who's unreconstructible, but who has a wound like that. You still engage, you still involve, but they're not the sort of patients that you're going to want to do anything very dramatic with while they're still with us. But you're still involved in that wound care, because if they then have an increased level of pain or infection develops, then that is an indicator for amputation for them. So it's all about preserving and making sure, if nothing else, they're free from pain. Selecting dressings. Well, now there's a big market. Consider the following. What stage of healing is that that's in front of you on that day? What has caused your wound? What types of tissues are you going to be trying to manage? And the patient in general and that environment, if the cat's running about. In Northern Ireland at this stage, we had well over 400 dressings available to practitioners. It will be the same here in England, Scotland, Wales. I don't think we've separated yet from Scotland if we're going to. Keep that one out of it. So, the whole consistency of care, and in Northern Ireland we moved to therapeutic tendering. But how would you ever, in a month of Sundays, decide which of those products you would use for your patient? Okay, so it's all about your knowledge. You need to know, and it's not the freebie you got from the company rep along with a pen. It's what you're trying to do with that product for those tissues on that day. So what does that wound in front of you need? What have you got to address? Have you got lots of exudate that you need to try and mop up, soak up? Have you got a very dry, painful wound? Have you got one of those big black toes that you're just watching and monitoring and waiting for nature to take its course to an extent? What does that product do? So you need to be aware of what it does, and you need to be able to make an informed decision. How well does it do it? What's your experience with it? What does that patient need? What's available? Depends where you work. Is there any evidence to support the product? And this is where wound care really does lacks evidence. Okay, it's very, very difficult to develop trials into wound care products for lots of reasons. And what skills do I need to use the product? Is it a matter of opening the packet and slapping it on? Or do I need to know that I cut it a centimetre larger than the wound because it's going to shrink with the exudate in the wound? You need to know what you're using. How long should it stay in place? How much is it going to cost? Am I going to have to get a district nurse to go out daily because this patient's going to need daily dressing changes? Or can it stay on for a week? And am I going to be sure that it'll be changed after a week? Or will the patient think, I'll be all right for another few days, and you end off with problems? And the other thing, which is a bit of a hobby horse, is people who put together several products and create their own concoctions. Now, it's not necessarily your betadine, olive oil and 2 pinches of salt type thing, but combining products. What is the point in putting something like a hydrogel on a wound and putting a piece of foam on top? Because the foam's designed to soak up stuff, and the hydrogel's a fluid. So is the fluid going to go into your wound, or is it going to just soak into your dressing and make a soggy mess? Likewise, Inidine that we all know and love, are you going to put it on a really moist wound? Because you know that Inidine will go white when it's been in wound contact. So if you've got a high level of exudate, is that the best product for your wound? They're costly. Diabetic foot ulcers are costly. As I said, morbidity, mortality, and hard cash to the health service. And there is still a lack of good data out there, even though that came from Henry Connor, 15 years ago. Some of the studies that are available, and I'm not going to labour them, there's one on foam dressings, a Cochrane review, and there's one on hydrogels. There's no evidence there to support these products in diabetic foot ulcers, because one of the exclusion criteria very often when people develop protocols for research is exclude the diabetic foot. It's too complex. William Jeffcoat, you've heard his name before from me, Tricia Price, etc., did an RCT looking at 3 different dressings. And if you talk to any of them, they will tell you the big challenge was they randomised the patient, and it was either NA, Inidine, or Aquacel. The likes of Aquacel AG, which is another antimicrobial, wasn't available at this stage. And the district nurse or another practitioner thought, you can't just use NA, which is just a silicone dressing, on this wound. You need to have something that's going to do something. And they persistently changed the dressing that the patient had been allocated to, so that they lost a lot of patients to the study because of interventions by other practitioners. But the only thing that they could conclude was there was no statistical difference in anything but the cost of the dressing. Nothing different about the effectiveness as they saw it of the 3 products. No difference in the quality of healing. No difference in the adverse events that were reported. The only thing that was different was the cost. So select the most cost-effective product and the most convenient. That was their advice at the end of that study. It's readily available online as a great big PDF. Current trends is what I said to talk about, and I know coffee's brewing out there, so I'm whistling on. Current trends at the moment in the world of wound care, your silvers, your honeys, which you read about all the time, even in the Daily Mail. Povidone iodine's still there for us as podiatrists, and a PHMB product. Silver nitrate has cytotoxic effects to your cells, to your ceiling cells, which is why I sort of cringe when somebody puts silver nitrate around hypergranulation tissue on a wound. It's shown to be cytotoxic. There's lots of different forms of silver. Silver dressings are extremely expensive. There's different types of them. You need to read your company blurb. I'm not going to labour what the different dressings are and what they do. But already some resistance has been shown to these. And the problem is they look to be doing the job, so they continue to slap them on. Clinicians need to step back and think, I've been using this for an X number of weeks. It's an antimicrobial dressing. Do I still need it to address a bacterial burden here on my wound? So it's just very quickly. Silver's still there. It's still on trend. There's a few articles starting to come out about the use of copper. Honey is very much flavour of the month for lots of reasons. If you use it on your patients, they may report stinging. Honey has a very low pH. Infected wounds will have a very high pH, and that is what causes, back to your basic chemistry of putting an acid into an alkaline, and in some patients there seems to be some sort of a chemical reaction, and that may cause stinging in about 50% of your patients. There are different forms of honey, and we know that its antibacterial activity works against Staph aureus, E. coli, Pseudomonas, MRSA, and the other thing we're using it for in clinical practice, along with silver, is these biofilms that people have started to write much more about in wounds, which is that jelly-like substance in some wounds that you're now lifting off, and years ago you thought, what is that anyway? Biofilms. And there's a nice review, if you want to read some more about honey, published a few months ago. Inidine, we've used it for years. There is no real evidence to support it, apart from the fact that the work done on rabbit ears shows that povidone iodine is destructive to your fibroblast. But despite the lack of evidence, we continue to use it. And we use it on those necrotic toes where we're working to our line of demarcation as a little antimicrobial. We use Inidine for lots of things, and yet the evidence isn't there to support it as a wound care product. Negative pressure wound therapy. A few years ago there was the pictures of the soldiers coming back from Afghanistan with their big TNP systems, topical negative pressure, as opposed to people talk about VAC, which is one of the products. But there are lots of different products out there, but they're known to work by creating a negative environment, stimulating angiogenesis, stimulating your granulation tissue, removing the slough, addressing the exudate, all of those things. But it's an expensive product, and it works nicely if you choose the right product for the right wound, which is the message in general. PHMB has come onto the market in the last couple of years. It's a polyhexamethylene biguanide, and it works by binding to your bacteria. No reported resistance so far. What's available to us is a foam. But we know it's effective, and there is evidence, good evidence, to support its effectiveness against all of those organisms, including good old MRSA and Pseudomonas. Dermacen's something that our vascular surgeons like to use. It's basically bleach solution, and they use it as a wound soak to again address the bacterial burden topically. But it has been shown to be very effective against both Pseudomonas and MRSA. It's only available with us through prescription by the surgeons. Managing diabetic foot wounds, your area, get the pressure off it. It's not what you put on it. It's not the dressing you put on. It's get rid of that pressure, get rid of the infection. And of course the gold standard, especially for your neuropathic wound, are these total contact casts. Some people make Scotch casts. It depends what's available. Air cast if you must. And then when you get them healed, look at their footwear, look at the insoles, and get the pressure off, and hopefully you'll prevent recurrence. And there's a lovely review by Professor Kavanagh and Seiko Bus. And we can get you the PDF if you'd like to read that. A really nice review, and saying, despite what's available, we're not using what we should do. Briefly. Very nice paper. Impaired wound healing and diabetes, everybody knows about it. If you're a diabetic, you won't heal as quickly. Look at your underlying pathologies and mechanisms. I said no dressing will ever heal a wound for you. In the past, we've had things like Dermagraft, which was a fibroblast replacement tissue. It was made in America. It was developed from the foreskin of neonates. It was living tissue, but we had issues with infection. It's coming back on the market. That little packet of Dermagraft was £250 a packet, and they said 8 for a treatment for neuropathic ulcers. We also at a stage had Regranex, which was a synthetic growth factor. It was £250 a tube, and what I think it was Professor Kavanagh was referring to earlier on, The data that didn't support it was never published. The research was supported by the companies, and the evidence to say it was not an effective product was never published. We also have had Zelma for a while, but the company for some reason have withdrawn it. We don't know why. We had good results clinically with it, but it was the exception. It was the very difficult to heal wounds that we used it on, but it's not there for us anymore, and we don't know why as yet. So the future, very, very quickly, the future as I see it, and this is just me and I see it, we're still going to go back to growth factors. The big thing at the minute from the point of view of vascular surgery is therapeutic angiogenesis. There's a lot of research going on, and likewise it's known that diabetes as a disease has an effect on VEGF that stops its production. We know that from loads of research done in retinopathy, but there is now some evidence to say that exactly the same effects happen in the lower limb. So gene therapy, your therapeutic angiogenesis, is very much going to become something in the near future. And back to growth factors, and I put these slides in because you're musculoskeletal specialists, which is platelet-rich plasma. Autologous, it's used for lots of musculoskeletal conditions. We're using it for wound healing, but it's a portion of plasma fraction, autologous, from yourself, from that person, concentrated, whizzed down to produce something that is useful for the body's own growth factors. It's giving you back what's yours in a concentrated form. It enhances the work of the extracellular matrix and in general cell proliferation. There's loads of evidence there. This is Regen's machine. It's the one I know and I've been working with. Patient's own blood, spun, centrifuged. You end off with this. After the first centrifugation, this is the patient's own thrombin in this one, and this is the surgical system because I was doing some research with it, so I was able to put that into my double syringe and a needle in the end because I was working in a microbiology lab with it. But it's there, and there's lots and lots of work has been done in musculoskeletal medicine, but it's not good quality. We need a good quality randomised controlled trial. Used for lots of things: cardiac surgery, orthopaedic surgery, dentistry, sports medicine, veterinary practice for the good old racehorse. Extremely expensive, I believe, to deal with. Diabetic foot, there's one good paper by Driver. And of course, rumour has it Tiger Woods has used it to enhance his hair growth. We know it has antibacterial properties. We know that it is effective against Staph aureus and E. coli. And something I have done shows that that is equally so in our patients with diabetes. So there are antibacterial benefits to your PRP gels. Remember, when you're managing these diabetic feet, it's infection, it's the blood supply to those tissues, it's the pressures and the traumas. And remember that poor management will delay healing and keep those as chronic wounds. What do you need to know? You need to know how to assess before you treat. The identification of infection, vascular supply, your debridement, your dressing selection, that quartet of your hyperglycemia, your hyperlipidemia, your hypertension, and the smoking. Always, always, always check the other foot, assuming it's there. Offload, offload, offload. Select good footwear. Get it made if needs be. Reassess, reassess. Push your chair back and think, why is this not healing for me? And team care, because as I said, prevention is better than cure. Diabetes, more than any other disease, lends itself to team care. And a final one for you. So what? Diabetic feet. Not my thing. But when you look at diabetic foot wounds and amputation, are they any worse than the cancers? You're better to have prostate cancer, to have had an MI, to have breast cancer, or a Hodgkin's lymphoma than a neuropathic ulcer from the point of view of your mortality and morbidity. Colon cancer is worse to have than a neuropathic ulcer, but better to have, so to speak, than an ischemic ulcer. And the only things deemed worse from the point of view of morbidity and mortality are lung cancer and pancreatic cancer. Diabetic foot disease is brutal, it's costly, and it's costly from the point of view of mortality. And I'll leave you with that one. Thank you very much.